Okay, so a very good evening to everyone. Let me check how many of you have joined, how many students are there. Just say hi in the live chat box on the YouTube so that I'll know how many of you are online. Okay, so we'll wait for 1 or 2 minutes for more students to join, and after that, I'll start the session. Hi, Ada, Gauri, good evening. Hello, Saksham, Ria, Gagan, Dr. Ulfat. So, guys, many of you might be very much new to DBMCI, and some of you might be knowing me. So, let me first introduce myself. I'm Dr. Divya Gupta, Periodontics faculty at DBMCI, and okay, good evening, everyone. So, I'll just give a short introduction of myself. I'm Dr. Divya Gupta, Periodontics faculty at DBMCI, and guys, I have done my graduation and post graduation from GDC Ahmedabad. I completed my post graduation in 2018. So, yes, this is it. So, now let us start the class of periodontics. So, basically, our 1.5 hour session will be on this YouTube live, and here the doubts which you all have, you can post those doubts in the comment section in the YouTube. I'll not be taking the doubts like during the class because it breaks, the continuity of the class. But after I complete the topic which we are going to study, I'll take the doubts at the end. Okay. After 1.5 hour of this session of YouTube session, we'll shift to our DBMCI app. And when we are on app, you can ask your doubts in the Telegram group. Okay, guys. So the Telegram group which has been created for the year 2025, you all can ask your doubts on that group. Okay, clear everyone? Good evening to all of you who are here. So guys, with that said, let me start. Uh, let me tell you how we will be going till 26th. Okay, we are here till 26th. We will be meeting mostly every day till 26th, and in these days, today I'll be covering normal periodontium, and if time permits, I'll start with dental plaque also. I'll try to cover dental plaque also. So basically, guys, what is there? Periodontics, what I have seen is most of us, uh, we are not that much aware about the concepts which are there in perio. Okay, we are a basic anatomy about the periodontology is not clear. That's why whenever we go to the surgical part, we become confused. Arey, what is attached gingiva, what is lack of attached gingiva, what is keratinized gingiva? These terminologies confuse us a lot, right? That's why today the first topic, which is gingiva, it is very important for your MCQs as well as for your concepts, because whatever we will be studying after this, like gingival diseases, periodontal diseases, various clinical features, various treatment modalities, in those uh, in all those topics we will be using terminologies, and you should be clear, okay, what does all those terminologies mean. Okay, so I'll show you the pictures and images, and I'll try to clear all your concepts by 26th, so that it will be easier for you all to diagnose the gingival diseases which are there. Even when you go outside, when you practice in your clinics, most of the periodontal diseases go unnoticed. They go unnoticed, and I'll tell you that approximately 50 to 60% of the patients which come to our clinics, they means they have periodontal diseases, they have periodontitis, and if we diagnose it correctly, and if we know how, if we can explain the patients okay, what will be the consequences of these diseases, we can make them agree to get the treatment done, right? So that is what will be my main aim till 26, so that your concepts are clear about periodontics. Second thing is, see, try to listen as much as possible. Okay, don't try to correlate whatever I am saying to the notes which have been given to you. Okay, those notes are from recorded videos which we have made. Videos are made from a different perspective, and live classes are done with a different vision. Live classes are done so that we can directly interact with one another. You can ask your doubts directly to me. So if you will listen, uh, you will be able to understand the concepts, and then you will have doubts, and those doubts we can clear in the class only. Okay. So with that said, let us start with the first topic, which is gingiva. So what is gingiva? What is gingiva? Gingiva is, by definition, gingiva is a section of mucosa, or it is a part of mucosa, section of oral mucosa, which it is a section of oral mucosa which covers the bone, and roots of tooth, right? So this whole part which you see here, this whole part is your gingiva, which is covering the bone and the roots of the tooth. Okay, understood? Now, let us see the different parts of gingiva. Different parts of gingiva, and this is very, very important. You might feel that this is not means all these things you already know, guys, but no. I have seen students asking me doubts, and from anatomy itself, these are the basic things which you need to understand. Okay, so here we can see two views, right? This is the facial view, this is the facial view, and this is the proximal view of the gingiva. How the gingiva will look when I'm seeing it from the facial aspect, and how it will look when I'm seeing it from the proximal aspect. So the first thing that is visible to me is the marginal gingiva, this part of the gingiva. This is the marginal gingiva, the highest point of the marginal gingiva. This highest point of the marginal gingiva is called as gingival zenith. Okay, this is called as gingival zenith, and this marginal gingiva continues below as free gingival margin. This is the, sorry, this part is the margin, sorry, this is the free gingival margin from where it begins, and from free gingival margin up till this depression, this part is your free gingiva or marginal gingiva. Why is it called as free gingiva or marginal gingiva? Because whenever I'll insert my probe here, okay, when I'll insert my probe here, it will get separated from the tooth. That's why it is called as free marginal gingiva. Okay, and this groove which you see here, this groove which you see here is seen only in 50% of the cases. In remaining 50% of the cases, this groove is not seen, and this groove is free gingival groove or marginal groove. This groove is free gingival groove or marginal groove. This groove is seen only in 50% of the cases. This is an important MCQ which has been asked previously. So, I'll just mark the MCQs with a star. Okay. So, this free gingival groove is present only in 50% of the cases. So, how we will determine the location of free gingival groove in the remaining 50% of the cases, right? So, in those remaining 50% of the cases, what we do is, we'll take a probe and we will insert the probe inside the free gingival margin or marginal gingiva or the sulcus. We will insert the probe there, and the depth up till which the probe will go, the probe will stop at a point, right? When I'll insert the probe, it will stop at a point. This probe will stop at a point, and at that point I'll see an external projection. I'll see the elevation of the tip of the probe, right? From outside, I'll see a elevation here. That elevation denotes the location of free gingival groove in a healthy mouth. This is what I'm talking is about the healthy gingiva. Okay, we are not discussing about any gingival or periodontal diseases. We are just discussing about a healthy gingiva. So this is a healthy mouth. In a healthy patient, you will see all these features which I am telling you. Okay, so in the remaining 50%, you will see an external projection of the probe, and that external projection of the probe denotes the position of the free gingival groove. Now, the position from here, from the free gingival groove, up till this point, this dark red line which you see here, this dark red line is what? This is the mucogingival junction. Mucogingival junction. Here, it is mentioned here, mucogingival junction. This dark pink red line which you see here, this is the mucogingival junction. So, the area between the free gingival groove, free gingival groove and the mucogingival junction means this area denotes your attached gingiva. This is your attached gingiva. Now, why is it called as attached gingiva? It is called as attached gingiva because it is attached to the underlying tooth and bone. When you see it from the proximal aspect, you can clearly make out that this attached gingiva is firmly adherent, right? It has ready pegs, and through this ready pegs, it is attached firmly to the underlying connective tissue, and with that it is attached to the tooth. Also, with the tooth, also it is attached to the underlying bone, right? It is attached to the underlying bone. That's why it is called as attached gingiva. Now, this attached gingiva is a very significant structure to us. Why? That we will know. So, this part, this attached gingiva, okay, this attached gingiva, this marginal gingiva, the attached gingiva, the marginal gingiva, the interdental papilla, all of this gingiva is keratinized gingiva. This is one question which, many students ask me that which amongst the following, which parts of gingiva are keratinized? So, attached gingiva, marginal gingiva, and interdental papilla. Interdental papilla, we will study about this also. All of these structures are keratinized gingiva. Now, from here, from the marginal gingiva up till the mucogingival junction is your keratinized gingiva. Okay, all of this This is the marginal gingiva, not only up till here, but this pyramidal shape thing which you are saying between the two teeth. This is your interdental papilla. So this plus this plus this, all of this is your keratinized gingiva. So another important thing which you must know is the minimum minimum width of keratinized gingiva should be 2 mm, and the minimum width of attached gingiva guys, please keep posting your doubts in the comment section because it disturbs me a lot. I'm not seeing it currently, okay, but at the end of the topic I'll see all your doubts in the comment section. I'll answer them, okay. So just keep posting your doubts. I'll not take the doubts in between because it breaks the sync. So the minimum width of attached gingiva is 1 mm. Minimum 1 mm should be present. And why is it so? Why the scientists have come to a conclusion? So this is a fact which you must know, okay? But why they have come to the conclusion that the minimum width of keratinized gingiva should be 2 mm, the minimum width of attached gingiva should be 1 mm. Why they have come to this conclusion is because, see, whenever there is plaque accumulation, suppose here there is plaque accumulation, okay, here there is plaque accumulation here, okay. So scientists found that if this width of attached gingiva is less than 1 mm, what will happen? The bacteria releases its toxins, right? Here bacteria is there, here bacteria are there, and this bacteria, they release toxins. This also we will be studying in dental plaque. So these and host modulation, the pathogenesis, we'll study this, but I'm just briefing you out why minimum width came to 1 mm of attached gingiva, okay. So the bacteria will release its toxins. So if the width of attached gingiva is less than 1 mm, these toxins can easily reach the connective tissue and the bone, and they can start causing bone destruction. This is called as radius of action. Radius of action. What happens is the bacteria in the plaque, it is seen that when the bacteria in the plaque, they release toxins, okay, and these toxins can exert their harmful effect. These toxins can exert their harmful effect up to distance of 2.2 to 2.5 mm, and this is what is called as radius of action. So if this 1 mm of attached gingiva is present here, there will be enough space between the bone and the bacteria, and they will not easily reach the bony tissue and cause destruction of the bone or loss of connective tissue and bone. Okay, that's why the width of attached gingiva is very important. Okay, understood? I hope it is clear. Now, in the width of attached gingiva, it is maximum. This is important for MCQs. It is maximum in maxillary central incisor, which is 3.5 to 4.5 mm, 3.5 to 4.5 mm. Next, it is in mandibular central incisor, which is 3.3 to 3.9 mm. The width of attached gingiva is least. It is least in maxillary premolar, which is 1.9 mm. and then in mandibular premolar, which is 1.8 mm. This is a very important point for your MCQs. It has been asked previously. This width of attached gingiva increases. This width of attached gingiva, okay guys, this width of attached gingiva increases up to the 4 years of age, and as the age increases, as in older age groups, you will see there can be either increase in the width of attached gingiva or decrease in the width of attached gingiva. Okay, there are some patients who show that there is increase in the width of attached gingiva. Some patients show that there is decrease in the width of attached gingiva, and how this decrease and increase occurs, that also we will see in the age related changes in the gingiva, that chapter which we will be discussing today. In that you will see how this increase or decrease occurs. So in older age group patients, you will see that there can be either increase or decrease. Okay. So the width of attached gingiva increases up to the age of 4 years of age. It can increase in patients who have supra-erupted teeth. Okay. Now, this width of attached gingiva, the thickness of the width of attached gingiva is very important. This thickness. I'll just rub this. So this thickness of width of attached gingiva is very important. And how do we measure this thickness of attached gingiva? This question was also asked in your MCQs. This thickness of attached gingiva is called as gingival biotype. Okay, this thickness, or you can say this, all this thickness of gingiva, it is very important. This is the thickness of gingiva, right? So how this thickness, this is called as gingival biotype, and how this gingival biotype is measured. Gingival biotype, it is what? It is gingival thickness, and it is measured with an instrument which is called as color view probe, which is called as color view probe. This question has been asked in your MCQs. And what is color view probe? This also I'll tell you. So guys, this is a So this is a color view probe. In the MCQs, this image was given. And it was asked to identify where these probes are used. So these are the 3 color view probes, and it is not like only one probe is used at means this is a set of 3 instruments. These are like you have to buy all 3 of them. One single instrument is of no use to anyone. Okay, so this is by Ufredi, and these color view probes, these are used to check the thickness of gingiva. So here you can see in the image that these probes are inserted into the gingival sulcus, and they are visualized under the headlight, under the chair light. They are visualized. And first, the probe with the white end, this is number 1 probe. Here you can see the markings also, 1, 2 and 3. Okay. So first the probe with white band or the white tip is inserted. And if this white probe is inserted and it is visualized in the light, if the white color is visible, if the white color of the probe is visible, then the gingival biotype is considered as thin. It is considered as thin. If this color, white color, is not visible, we will take the second probe with green band, and we will insert it. If this green band is visible, we will consider the gingival biotype to be medium thick gingival biotype. If this green band is also not visible under the light, we will take the third probe, which is the blue band probe and we will insert that probe. If that blue color is visible, then it is called as the thick biotype, and if it is not visible, thick biotype, and even if the blue color is not visible, then it is called as a very thick biotype. The gingival biotype is considered to be thick. Now, why do we need to understand the thickness, right? So, whenever we are going for any mucogingival surgeries, recession coverage surgeries, or whenever we are planning a case for orthodontics specifically, so what sometimes in future we can predict, okay, there can be, if the gingival biotype is thin or medium thin, there are chances of more recession, right? Why? Because in orthodontics we are moving the tooth. So if the gingival biotype is thin, there will be more recession. Okay, so these color view probes are very much important to us to determine the thickness of the gingiva. Accordingly, we can pre-inform the patient that there are chances of recession in future, whichever patient is undergoing orthodontics, or whenever we have to take a graft from somewhere, right? A gingival graft we have to take. In those cases, if the gingival biotype is thin or medium, we will not take a graft from the adjacent tooth, right? We will not take, we will think of some other place to take the graft. So this is why the color view probes are important. Now, this is about the attached gingiva. Now, in the attached, after the attached gingiva, let us come to the next important part, which is the mucogingival junction. Now, this mucogingival junction is the junction between the attached gingiva and the alveolar mucosa. Now, after the class, after today's session, I would request all of you to look into the mirror and try to identify all the parts of gingiva whichever parts I'm telling you right now. Look into the mirror and see all the parts in your mouth. Try to observe. Only then, and this is just a small exercise, and this small exercise will help you to determine many things in your patients as well. Those things we will understand later when we proceed with our classes. Okay, but try and visualize all the anatomical structures of gingiva today in your mouth, in your own mouth, in the mirror. Okay, so now next is the mucogingival junction. This mucogingival junction, the most important thing to remember is it remains constant throughout the life. It remains constant throughout life, means the position of mucogingival junction does not changes. Then how does recession occurs, right? Recession occurs because what changes? The position of marginal gingiva. This gingiva will recede downwards, but this mucogingival junction, it will not move. It will remain constant, guys. Okay, remember this. Mucogingival junction remains, the position of mucogingival junction, position of mucogingival junction remains constant throughout life. This position will remain constant. And how does recession occurs? Because of the recession of this marginal gingiva, as well as something which is here, which is called as junctional epithelium, about which we will be studying. Okay, so this is what is mucogingival junction. Then comes the alveolar mucosa. Alveolus means your bone. Mucosa, which is covering the bone. This is the alveolar mucosa covering the bone. Okay, so this dark red or dark pink part which can be separated, this dark pink part is what? It is your alveolar mucosa. Okay, now the next thing which you need to know is the sulcus. What is a sulcus? So the space, it is, what is a sulcus? A sulcus is a V-shaped space. This is a V-shaped space which is present between the tooth and the gingiva. It is a V-shaped space here. Here in between, this space is there, right? This space is there. This space is called as the sulcus. So, what is sulcus? Sulcus is a shallow V-shaped space present between the tooth and the gingiva. Okay, how do we check where is the sulcus present? I told you we have to insert a probe. So that is your sulcus depth. Whenever I am inserting the probe and the position where in a healthy mouth, where will the probe stop? It will stop at the point of free gingival groove, right? Where it is attached to the underlying tooth. From where the attached gingiva, see, try to link, okay? In a healthy mouth, where will the probe end? It will end at the location of the free gingival groove until here, from where the attached gingiva starts. Attached gingiva is attached to the tooth. Free gingiva is separate. Okay, so till the attached part my probe will go, and that is your free gingival groove. This is about healthy mouth. In unhealthy mouth or in cases of gingival diseases, what happens is my probe will penetrate deeper. It will go deeper when there is pocket present, right? In cases of periodontal diseases, the probe will go deeper. So that is your periodontal depth. So this is the, when the probe is penetrating here at the sulcus, it is called as sulcular depth. Sulcular this is called as the sulcular depth. Now the sulcus depth, ideally the sulcular depth, ideal sulcus depth should be 0 mm. This is important for MCQs. If you want to write it down, you can write it down. Otherwise, it is given in notes as well. Histological sulcus depth should be, histologic means sections were taken of the gingiva, they were studied under the microscope and it came out to be 1.8 mm. And optimal sulcus depth, which should be there in normal mouth, optimum depth of sulcus which is seen in normal mouth or in a clinically healthy gingiva, it is 2 to 3 mm. Okay. Now, one terminology which many a times is asked is the clinical attachment level. Clinical attachment level. What is clinical attachment level? See here. I told you from where the attached gingiva starts, below the free gingival groove, until where it is attached, till below, till the alveolar mucosa, right? Like it continues till the alveolar mucosa. So that whole part is your attached part. That is your clinical attachment level. This whole part which is attached here, this whole part from the free gingival groove, this whole part is your, this is your clinical attachment level. And in the questions, sometimes it is asked that calculate the clinical attachment loss in this case. So first you have to be clear that what is clinical attachment loss. Now let us see some of the scenarios, so that mostly I cover this in periodontal pocket, but as we are, I have told you what is clinical attachment level. I'll just tell you three scenarios and how to calculate the clinical attachment loss. So what happens if there is recession? What will happen in recession? Whole of this structure will be going downwards, right? In recession, whole of this structure is moving downwards. along with marginal gingiva. So the new position of the marginal gingiva will be like this. Suppose I am taking the first scenario to be recession. The first scenario to be recession. This is the tooth. This is the tooth. Here there is recession. Okay. This is what? This is your CEJ, cemento enamel junction. Recession is calculated from the cemento enamel junction up till the marginal gingiva. Okay. This is, suppose this is 2 mm. And then we calculate the pocket depth. What is the pocket depth? The pocket depth is from the marginal gingiva. The pocket depth is from the marginal gingiva up till the apical penetration of the probe. This is pocket pocket depth. It is from this. All we will study again, but I'm just telling you in short what is clinical attachment loss means. So pocket depth is marginal gingiva from marginal gingiva up till apical penetration of probe. This is what is your pocket depth. Okay, so when I am I'm putting my probe here. I'm putting my probe here. This pocket depth came out to be, suppose, 4 mm. So what is the clinical attachment loss in this case? From the clinical attachment loss will be calculated from the cemento enamel junction up till here, right? This much tissue is lost. This much attachment to the tooth, attachment of connective tissue to the tooth is lost. This is what is clinical attachment loss. So in this case, what is the clinical attachment loss here? 2 plus 4. Clinical attachment loss is 2 plus 4 is equal to 6 mm. Understood? What is clinical attachment loss? This is whole of this connective tissue is attached to the tooth. So this is your clinically attached tissue, and when this tissue is lost in the cases of gingival diseases, that is called as clinical attachment loss. Now I hope this terminology is clear. This is I just gave you one example. I will be discussing this again in the periodontal pocket chapter. Okay, I'm right now not discussing this. I just gave you this example so that it will be clear for those for those who have not enrolled also. Those students are also there. So I just thought I'll give you a brief idea about what is clinical attachment level, clinical attachment loss. Okay. So I hope it is now clear what is clinical attachment loss, clinical attachment level. So two terminologies we studied here. Sulcular depth. What is sulcus depth? From the marginal gingiva up till the apical penetration of the probe. This, okay. Sulcus depth is the from the marginal gingiva up till the apical penetration of the probe is your sulcus depth. Then we learned about the clinical attachment level. Next thing which is important is your transgingival probing. This is also asked in exams. Transgingival probing. Okay. Now this transgingival probing, what is this? This is also called as bone sounding. We get questions on this, right? We get questions on this. So what is this transgingival probing? So guys, we take the probe. I'm inserting the probe and it is penetrating till here. Okay, this probe is penetrating till here. This is your sulcus depth or pocket depth, right? Sulcus or pocket depth. But in certain conditions, such as crown lengthening, whenever I'm planning for crown lengthening, whenever I'm planning for smile designing, right? When I have to cut the gingiva, I have to lengthen the crown. We need to know the level of the bone. So what I'll do, I'll take my LA, I'll give an infiltration on that particular tooth, and I'll take the probe and I'll insert it deeper up till the alveolar crest. So I'll take the probe, I've given infiltration, okay? Without infiltration, you cannot do this because it is painful. And I'll insert the probe from here up till the alveolar crest. And then I'll know the exact location. I'll know the exact location of the bone. That is called as transgingival probing. So now the next question which comes is probing force. Most of the questions which are asked in the exams I'll cover here, guys. Okay, so this is controversial question, not controversial, but yes, there are different books which are giving different answers to this question, right? So the probing force, probing force, the force which is used to check the sulcus or the pocket depth. In healthy gingiva you will see a sulcus, but when there is increase in the sulcular depth, it will lead to the formation of pocket, that is called as pocket depth. So when you are, the force which is used to check the pocket or which is used to check the sulcular depth, that force should be 25 grams. It should be 25 grams. Okay, some books are writing it as 0.75 newtons, but if in the options, if the value is asked in newtons, it should be 0.75 newtons, but basically it is 25 grams. Next is transgingival probing force, or which we studied right now. Okay, bone sounding, how we check the bone sounding. We need more force to insert the probe till the bone, right? We need more force to penetrate it up till the alveolar crest. So that force is up to 50 grams. That force is up to 50 grams. Now don't get confused and ask me again and again the same question. What is the probing force? Is it 25 grams? Is it 50 grams? If it is asked probing force, it is 25 grams. If it is asked transgingival force, it is 50 grams. Okay, probing force is 25 grams. Remember this. Okay. So with this, we have covered maximum about the sulcus, the sulcular depth, the clinical attachment level, the transgingival probing, the periodontal means the probing force which is required to check the sulcular depth. Now the next thing which can be seen is the interdental papilla, this part. Okay, this part. This pyramidal shaped structure that can be seen between the two teeth, this is called as the interdental papilla. This interdental papilla in the anterior tooth interdental papilla in the anterior tooth in the anterior tooth, it is pyramidal shape. Remember this, pyramidal shape. And into the posterior tooth, it is caul shaped or tent shaped, caul or tent shaped. Now this caul, whatever I'm marking with red is important for MCQs. It has been asked previously. Those questions I'm marking with a star, okay? Or writing in red. Caul is located in the interproximal area. Proximal area. It is non-keratinized, and it is highly colonized by bacteria. These are the points about col which have been asked in the exams. So highly colonized by bacteria. As it is highly colonized by the bacteria, it is most prone to periodontal disruption. It is most prone to periodontal disruption. Okay, clear with the clinical features. This one topic about clinical features, is it clear, guys? Now I'm opening the chat. I'll just look at your doubts which are there. If I can see any doubts, I'll just answer them quickly. And then we'll go to the microscopic features. Now the next part is the microscopic features of uh, okay, what we have completed yet, ma'am. Okay. So for that, Nikhil, you can rewind the video. Now, Apur, ma'am, the radius of action of bacteria in plaque. Yes, the radius of action, you want to know the mm, it is 2 to 2.5 mm in plaque, the radius of action. Radius of action, as the name suggests, the radius of action means up till where the bacteria, the toxins, the bacteria will not go there, right? The toxins which are secreted by the bacteria, they will cause the destruction in the surrounding tissue. So they can cause the destruction in the surrounding tissue up till the distance of 2.5 mm. That you have to remember, 2 to 2.5 mm, okay? Understood, Apurva? I hope this was your doubt. Then Poonam. Ma'am, is there any specific marking on color view pro, or only the color is used? Only the color is used, beta, because we are visualizing the color. There is no marking. We are not checking the pocket, right? We are just visualizing the color to check the thickness. We will not see the color is used as a marking so that it will be visible from the light. When we'll see it from outside, that color will be visible depending upon the thickness of the gingiva. Okay. In marginal groove, Kang Nath. In marginal groove, your question is incomplete. I'm not understanding it. Vishwa, ma'am, will this not breach intact gingival epithelium? Ma'am, will this not breach intact gingival epithelium? Yes, you mean to say about you are asking Vishwa about transgingival probing, right? Yes, it will breach the intact gingival epithelium, but we are not doing it throughout. And anyways, we are not in healthy mouth. We are not doing it. Whenever we are planning for a treatment, in only those cases we are penetrating the probe up till the alveolar crest. Whenever I am planning for crown lengthening, or whenever I am planning for smile designing cases, in those cases only we are doing transgingival probing. Okay. Repeat the transgingival probing. Basically, transgingival probing is what? I'm taking the probe, and we have to give infiltration. We have to numb that area, and through the sulcus, I'll penetrate up till the alveolar crest. Now your question will be, will the probe go till there? Yes, it will go, because it is soft tissue and I'm using a heavy force. After numbing the patient, the patient will just feel the pressure. He or she will not feel the pain. You have to insert your probe up till here, up till the alveolar crest. That is your transgingival probing. Understood, Arti? Diksha, ma'am, please repeat clinical attachment. Please repeat probing force portion. I have repeated it, Aditi. Clinical attachment, I'll repeat it again. See, ये क्या आ गया यार? I don't understand. Okay. So clinical attachment. Clinical attachment level means clinically where your connective tissue is attached to the tooth. Okay, clinically Now here, I told you that marginal gingiva is not attached to the tooth. Marginal gingiva surrounds your sulcus. Try to imagine, guys, this is your sulcus, right? This is your sulcus, and this marginal gingiva is surrounding. It is one of the borders of sulcus, and from here, it is attached. It is attached to the tooth, right? Here, this whole part is attached to the tooth. This whole part is attached to the tooth. That is what is your clinical attachment level. Now, this is in healthy mouth. Suppose we consider that there is recession. In recession, what will happen? In recession, what will happen? This gingiva, it will recede downwards, right? It will recede downwards, and the location of the new gingiva will be like this. How much tissue is lost? This much. This much attachment is lost. That is what is your clinical attachment loss. Understood? Uh, Adit, who asked to repeat? Diksha, understood? Okay. I hope I have now it is clear what is clinical attachment level. Ma'am, what is the thickness of gingival biotype? Gingival biotype is in itself thickness. There is no specific different person based upon the genetics, based upon the position of the tooth will have different thickness of gingiva. Transgingival, I have explained, ma'am, all parts of gingiva are keratinized. Then how is called non-keratinized? No, no, no. Where did I told you where that all the parts of gingiva are keratinized? Caul is located in between the tooth, right? Caul is located in between the tooth. If you will imagine it three-dimensionally, if I look at the tooth from the proximal aspect, okay? If this is the tooth, see, if this is the tooth from the proximal aspect, okay? In posterior tooth, I am telling you, this is from the proximal aspect. I hope you all understand what is proximal, what is facial, lingual. Please don't ask me to explain this. This is dental anatomy. You all must know it in the first year only. Okay, so if I am seeing the tooth from the proximal aspect and this is the gingiva, then this central part in the posterior tooth is your caul, and this part is non-keratinized. This part is non-keratinized and it is highly colonized by bacteria. This part is non-keratinized. The outside portion of the gingiva is majorly keratinized, but the inner portions can be non-keratinized. Outside portion acts as a barrier. It acts as a physical barrier, right? But caul does not act as a barrier. It is present between the two teeth in the interproximal area, so it is non-keratinized. Okay. Now, Aparajita ma'am, in exam they ask extent of attached gingiva. Ma'am, gingival zenith, please explain. Gingival zenith is just the highest point of gingival zenith is this highest point of the gingiva. This point is your gingival zenith. This point is your gingival zenith. Highest point of marginal gingiva is your gingival zenith. Okay. Level and loss I have explained. Prajita is asking, ma'am, in exam they ask extent of attached gingiva. I didn't get you. What is extent of attached gingiva? Can you please ask me an appropriate question? Means which question is asked? Just if you have that, post that, Prajita. Okay, ma'am. How we will know the crest has reached while probing? Is it the hardness? Yes, it is bone, beta. You are penetrating the connective tissue and then you will reach a hard surface. It is bone you cannot penetrate with a probe, right? It is very hard, so you will feel a stop there. That is your alveolar crest. In between is all connective tissue. Ma'am, when we give 25 milligrams or 0.7 milligrams saying grams or 0.75 Newton force, and when 50 grams of force, I'm not getting it, 25 grams you give in when you are just checking sulcus depth. When we are till here only, when we are just in the sulcus, you just have to go 25 grams. When you have to go do transgingival probing, now guys, understand that transgingival probing you will not do in every case. You will do it only in cases of crown lengthening, right? Transgingival probing you will not do in every cases. When you are just probing the sulcus, it is 25 grams. It is simple. Ma'am, zenith is on the marginal gingiva or in the sulcular epithelium. It is on the marginal gingiva. Zenith is on the marginal gingiva. Okay. So now, ma'am, can you see my question? Sanjana, ma'am, even attached gingiva is keratinized. Why difference? Ma'am, even attached gingiva is keratinized. Why difference in width like attached gingiva and keratinized? Yes. So attached gingiva is a part of keratinized gingiva, na? See, this is what I told you. Now whatever I'm marking with red is your keratinized gingiva. I told you this is what? This is your marginal gingiva. This is what? This is your attached gingiva. So marginal gingiva plus attached gingiva is your, this is your keratinized gingiva. Attached gingiva is also keratinized, but it is less. The width of attached gingiva will be less than the keratinized gingiva, right? So this part, now what I am marking with pink, this part is your attached gingiva. The minimum width of attached gingiva is 1 mm. The minimum width of keratinized gingiva is 2 mm. Understood? Attached gingiva is a part of keratinized gingiva only. You are correct. But keratinized gingiva is not a part of attached gingiva. So you must know that what is the minimum width of attached gingiva? What is the minimum width of keratinized gingiva? That should be there. Sometimes in the question, they will just give you the minimum width of attached gingiva is this much. Then you have to calculate the answer accordingly. And this we will see later on when we'll, read topics from mucogingival surgeries. You will understand the difference between keratinized gingiva and attached gingiva. Don't worry, guys. Okay. Okay, Sanjana, I hope it is clear. Now let us go to the microscopic aspects. The microscopic features of gingiva. Microscopic features. So guys, in microscopic features, don't try to read everything because in Carranza they have given so much and it is very difficult to read everything, right? So try to understand that microscopic features, not every time it is asked, only small things are asked, and that too in 3 to 4 years gap they will ask one question. So don't try to go very deep into the microscopic features. It is difficult to understand. It is difficult to understand for me also. It is difficult to understand. So just don't try to read it from Carranza, the microscopic features. Read it from our notes or pay attention here. Whatever I'm telling you right now, only that part is important. Otherwise, leave everything. Remember that you have to study 19 subjects. Everything you cannot remember. That is a truth. Kadwa sache, right? It is a bitter truth. And you have to understand that you will have to skip some things. And that is what is practical approach. That is what is like, bolte na, समझदारी वाला approach towards your exams. So don't try to go very much deeper into microscopic features. Whatever I'm teaching you right now, only that part is important. Okay. So basically, gingiva has gingival epithelium and connective tissue. Gingiva has gingival epithelium and then there is connective tissue and epithelium. Now this epithelium is important. Few points from this epithelium are very important, which you must know. The epithelium of gingiva is divided into three types of epithelium. Gingival epithelium gingival epithelium is divided into three types, which is outer oral epithelium, then there is sulcular epithelium, then there is the most important epithelium, which is the junctional epithelium. Okay, so first quickly let me tell you where these epitheliums are situated. So the epithelium which is covering this part is your outer oral epithelium. On the outer aspect into the oral cavity, on the outer aspect of the gingiva, it is your outer oral epithelium. Next comes your sulcular epithelium. This sulcular epithelium is this epithelium. The epithelium which is lining the sulcus is your sulcular epithelium, and lastly comes the junctional epithelium. This junctional epithelium is located here like this. It is located below the sulcular epithelium. It is located below the sulcular epithelium at the level of the CEJ, and it connects the connective tissue, the tooth and the sulcular epithelium. Okay, so these are the three important epithelium in the gingiva. Now, first later we will be studying about the outer oral epithelium and later about the sulcular and junctional epithelium. There are also different, these epithelium, they are made up of different cells. Okay, so this epithelium, the structure of epithelium basically is like this. So if this is the epithelium, it is a stratified structure. There are cells which are arranged in strata, means they are arranged in layers, right? They are arranged in different layers, and these layers are made up of different cells. Okay, these layers are made up of different cells. So these cells can be divided into keratinocytes, which constitutes about 90% of the cells of the epithelium, and then there are non-keratinocytes, which constitute your Langerhans cells. These Langerhans cells are your immune cells. They are used for fighting cells, right? Then there are melanocytes, which are responsible for melanin production. These cells are not that important. And then there are Merkel cells. Merkel cells are responsible for, they are sensitive, like there are free nerve endings. They carry the pain sensation, then they carry the pressure sensation, temperature sensation. So these are sensory organs which are present into the epithelium. Okay, now so so this is how an epithelium looks. Okay, this is how an epithelium looks. This is the epithelial, this dark pink structure, whole of this dark pink structure which you see here, this whole of this is your epithelium, and then comes the light pink structure, this part, this is your connective tissue. Okay, now here you can see that there are many cells, right? Here you can see that there are many cells. These are the retipex which are extending into the connective tissue like this, and these are the cells. Okay, so the cells which are at the base near the connective tissue, these are called as the basal cells. As we go upwards comes the stratum spinosum, spinous cells, then stratum granulosum, and then finally the stratum corneum. Okay, and here you can see that lot of fibrous tissue is there, and in between the dark blue structures which you see, that is the nuclei of the cells. These are the cells. So this connective tissue, there is lot of collagen which constitutes the connective tissue, and here this is the epithelium. Okay, so the cells at the base, the cells at the base, these are tall columnar cells. These are tall columnar cells which are located. So here is the connective tissue. This is the basement membrane. We will be studying this also. So these tall columnar cells located at the base, they are stratum basale. This layer is called as basal layer or stratum basale, and the cells here they are the keratinocytes. These one cell is called as one keratinocyte. These are tall columnar cells. You have to remember that these are the cells which are highly active cells. These are highly active cells. Highly active cells. Why? Because these cells receive the maximum blood supply, right? They receive the maximum blood supply from here. Whatever blood is coming to the gingiva from the connective tissue, these cells will be receiving like in the highest amount, and they have numerous cell organelles. Okay, they have numerous mitochondria, Golgi apparatus is there. Okay, so it is highly active. It produces a lot of energy, and this energy it can give to the other layer cells, right? And these cells divide at a rapid rate. These cells divide at a rapid rate, and they will, what will happen when these cells are dividing? These are like soldiers. Okay, these are line of soldiers. Some soldiers will remain at the base, and they will provide the nutrition, they will provide the arms to the fighting soldiers, right? So what will happen? Some soldiers will go in the field, some soldiers will remain at the base. Similarly, in keratinocytes also, some keratinocytes will remain here only. These are the keratinocytes. Okay, keratinocytes. So these keratinocytes will remain at the base. Some will divide. These will divide, and they will go further, and they will form another layer which is called as stratum spinosum. Okay, these cells are connected with each other with the help of desmosomes. Okay, so later these cells will further move upwards. These are keratinocytes only. Okay, the cells which constitute the epithelium are majorly keratinocytes. So these keratinocytes will further divide, and now they will form another layer which is called as stratum spinosum. And why is it called as stratum spinosum? Because when we look it into the microscope, we take a section of gingiva. That section is like, we have taken it and it is visualized in the microscope. It is not like that. We take the section of the gingiva, it undergoes a process of drying, and when it is dried, what happens is these cells lose their cytoplasmic contents, they will lose their water and everything, but they will remain connected with each other at the desmosomal junction. So this junction between the cells, this junction is called as desmosomes. Desmosome is cell to cell connection. Desmosome is cell to cell connections. The cells are connected with one another with the help of desmosomes. So they remain connected with one another, and they become like this. At whatever point they are connected, okay, they will remain connected, and at other points they will shrink. That's why they appear as spines, or they appear as star shaped. So it is called as stratum spinosum. Okay, here also the cells are active, the nuclei is active, and here in this layer, some important features are there, which is important. In stratum spinosum, we see that there is presence of odd-land bodies. Now, what is the role of these odd-land bodies? What are these odd-land bodies? So, this odd-land bodies is responsible for the production of acid phosphatase, acid phosphatase, and this acid phosphatase, what does it do? This acid phosphatase will be secreted by the cells in the stratum spinosum, and it will reach the stratum granulosum, and there it will start destroying the cells. So this is the function of odd-land bodies. Odd-land bodies are also known as keratinosomes, or they are known as modified lysosomes. Modified lysosomes. So what is the function of odd-land bodies? Odd-land bodies are responsible for the production of acid phosphatase. These are like granules, okay? These are like granules which are present here, and these granules will be secreting, these odd-land bodies will be secreting acid phosphatase. This acid phosphatase will reach on the above layer, and here the cells are more flatter. Okay, the cells in the stratum in the next layer, they are more flatter. The nuclei is also flatter. It is pushed towards the periphery. Slowly, this acid phosphatase, which is released here, right? The acid phosphatase, which is released here, what it will do? It will start destroying the cell organelles. It will start production of acid phosphatase. This acid phosphatase starts destroying cell organelles and cell membrane in stratum granulosum. So in stratum granulosum, you will see that most of the cell organelles are destroyed, and there is presence of small granules into the cytoplasm. In the cytoplasm, you will see that there is presence of small granules. These granules, how they appear suddenly, it is not known till now, but they appear. It might be because of coagulation of some cell organelles which are there, some proteinaceous molecules which are there inside, which are destroyed by the acid phosphatase and which are present into the cytoplasm of the cells, or which are present into the cell organelles. They might get coagulated and they give rise to keratinosomes, but exactly how they arise is till now not known. These granules which appear in stratum granulosum, they are called as keratohyaline granules. They are known as, these granules are known as keratohyaline granules, and because of the presence of these granules, this layer is called as stratum granulosum. Okay, slowly as the cells move upwards, the cell membrane is also destroyed, and what remains at the top is just, sometimes there can be pycnotic nuclei. Pycnotic means degenerating nuclei, or there can be just a matrix of cytoplasm which is rich in proteinaceous material. It is rich in proteinaceous material. So what happens is, the cells will get destroyed, and there will be lot of proteins here. Okay, keratin proteins. Sometimes you can see that there are pycnotic nuclei. There can be pycnotic nuclei present in this top layer. Okay, so if in the top layer, this top layer is called as stratum corneum. This top layer is called as stratum corneum, and the cell here are corneocytes. They are keratinocytes only, but they are completely degenerated. So now they are called as corneocytes. Okay. So now, if in the topmost layer pycnotic nuclei is present, then the epithelium is called as parakeratinized. If in the topmost layer, if in topmost layer, or you can say stratum corneum, Pycnotic. What is pycnotic? Degenerating nuclei is present, then it is called as, then it then it is called as parakeratinized layer. Parakeratinized epithelium or parakeratinized layer. If this pycnotic nuclei is not present, if pycnotic nuclei not present, or if it is all the cells are completely degenerated and only proteinaceous materials are present, then it is called as orthokeratinized. Orthokeratinized layer. And if this corneum layer is only not present, means the epithelium is not keratinized, right? If this topmost layer, if this proteinaceous layer is not present, then it is called as non-keratinized epithelium. It is called as non-keratinized epithelium. So there are three types of epithelium, which are parakeratinized epithelium, orthokeratinized epithelium, and non-keratinized epithelium. Let us have a look at all three of them. So here, see in this picture, whatever we have studied, now we will see. This is what? This is your basal layer cells, right? These are the basal layer cells. These are the cells which are present at the basal layer or basement near the connective tissue, near the basement membrane. Okay. We have studied these cells are very active. These are tall, columnar. They have rich blood supply. They can divide. They have high mitotic division. Okay. These cells, as they move upwards, they give rise to a more spinous layer, or the cells become more oval shaped. So that is called as stratum spinosum. Later on, as we move upwards, you can see that the number of nuclei are decreasing, right? The number of nuclei are decreasing. The number of organelles. Remember, it is dark blue means the cell is very active. It has large number of organelles. As the activity of the cells decreases, the number of organelles decreases, it turns to more pinkish in color. So here you can see that the bluish color is slowly disappearing. The cell organelles are disappearing. The cells are getting degenerated. See here you can see the vacuoles, white degenerated areas. So these are what is, this is your granular layer. Later in, after the granular layer comes the keratinized layer. See here. Here you will not see any nuclei at the topmost layer, at the topmost part. You will not see any nuclei. You will just see a pink layer because it is rich in proteinaceous material. Proteins such as filaggrin, involucrin, all these proteins are present in the topmost layer in orthokeratinized area, and this is called orthokeratinized epithelium. Now here in the topmost layer, in the stratum corneum, you can see that there is small blue dots. These are called as pycnotic nuclei, and this layer is called as parakeratinized. Okay, and lastly, there is no keratin layer present here. Okay, so in this layer, this is non-keratinized epithelium, and in non-keratinized epithelium, the layers which can be seen are stratum basale, the basal layer cells, then there is prickle cell layer or stratum spinosum, then there is an intermediate layer, and then superficial layer. These four layers are seen. Stratum granulosum and stratum corneum are only seen in parakeratinized and orthokeratinized epithelium. It is not seen in non-keratinized epithelium. Now, which are non-keratinized epithelium into the oral cavity? The non-keratinized areas in the oral cavity are called, one we have already studied, called, then there is sulcular epithelium, which is non-keratinized, then there is junctional epithelium, which is non-keratinized. Okay. Now, which is like parakeratin. Remember that most of the I'll just write it down. You can note this point. Most of oral epithelium is parakeratinized. Parakeratinized. Most of the oral epithelium is parakeratinized. Orthokeratinized epithelium, you can just remember that orthokeratinized epithelium is your gingiva, this palatal gingiva, gingiva of the palate, and some parts of the dorsum of tongue. Some parts of dorsum of uh, dorsum of tongue is orthokeratinized. Otherwise, this the gingiva, the interdental papilla, the attached gingiva, majorly these gingivas are parakeratinized. Okay, the cheek mucosa, the the lining mucosa of the oral cavity, it is non-keratinized. Okay, the lining mucosa. So non-keratinized epithelium is your sulcular epithelium, junctional epithelium, called lining mucosa. This is non-keratinized. Lining mucosa of oral cavity is non-keratinized. Okay. So if in the questions, now let us come to the questions. This is asked in the question, so you can mark it in red. This is asked, all these 3 points are asked can be asked in questions. And another important part that is asked is, which amongst the following the structure is highly keratinized or which is least keratinized? So the order in which the oral structures are keratinized, you can remember, is palate is most keratinized. Palate is most keratinized. This is a point to remember. Okay, then comes the gingiva, then the tongue or ventral aspect of the tongue, ventral aspect of tongue, and then comes the cheek. The cheek is least keratinized or it is non-keratinized. Okay, you can say cheek is least keratinized or non-keratinized. Okay, understood till here? So what we studied here? What we studied here, this process of conversion of the cells from basal layer up till the stratum corneum, this process is called as process of keratinization. It is called as process of keratinization. Now you know why it is called as process of keratinization, because the layers, as the cells are moving upwards, there is more production of keratin proteins, right? Keratin proteins, and the topmost layer is acellular. It does not have any cell. It is highly keratinized, and this keratin is responsible. It acts as a physical barrier. It protects the invasion. It protects the oral cavity, or it protects the gingiva from invasion of bacteria. It protects the gingiva from thermal injury, chemical injury. That is why it is keratinized. This keratinization process is also called as process of differentiation. It is also called as process of differentiation. Okay. Now, the next important thing which is important for you all to remember is the different keratin proteins which are present. Now guys, these keratin proteins are also called as cytokeratins. It is asked in exams, and you know, there is no logic or concept behind remembering these keratin proteins. You have to mug it up. So it is given in the notes also. You can go there. If you want to write it down right now, you can write it down, because uh, this is the difficult part in gingiva, to remember the keratin proteins. I was also not good in remembering these keratin proteins. Even now I have to refer the books, and sometimes when students ask, we have to refer books because this is very difficult for us to remember. So what I will tell you is, these keratin proteins you can write down. See, you have 19 subjects, okay? After 19 subjects, there is one book which I call it as 20th book. My seniors, my mentors have told me that make a 20th book, and in that 20th book, what you can do is write down the things which are difficult to remember or which are like impossible to remember, right? So in that 20th book, whatever you find difficult, or there is no concept or there is nothing you can do to remember it, just write it down there. Every morning, like when you get up, if you're getting up early in the morning, or when you go to bed, like before sleeping, once in a day, open that book and just go through it. Don't try to memorize it. Don't. Just go through it. If you will do this for 6 months, you will remember this. You will remember that whole 20th book. Okay. So this is one thing I tell my students, to write it somewhere, because it is difficult to remember. So whatever I'm going to tell you now, you have to remember it. There is no concept or logic behind it. Okay. So the cytokeratins, what are cytokeratins? These are the proteins which are present into the cytoplasm, and these proteins, these cytokeratins, they help in they are the skeleton unit of the cells. Okay, so what happens is, as they are already present in the cytoplasm, and as the cell is moving upwards towards the upper layers, and the cell organelles and the cell membrane is getting destroyed, these keratin proteins, they get organized in a layer, and these keratin proteins form the topmost layer only. So these keratin proteins are present even in the basal layer, they are present in the spinosum layer, they are present in the granular layer, they are present here as well. Okay, so now keratin proteins or cytokeratins of oral mucosa. Keratin proteins or cytokeratins of oral mucosa. Okay. Now, these cytokeratins are, write it down somewhere. Keratin K1, K2, K10, K11, K12. Always these 5 cytokeratins will be found together. Now, how you can remember it? K1, 2, K1 and 2. 1 के आगे we can put a 0, then it is 10. 1 के आगे 1 and 2. This is easier to remember. K1, 2, 10, 11 and 12. They will be together. They are called as epidermal type differentiation specific proteins. Epidermal type differentiation specific proteins. Specific proteins. And they are expressed with high intensity. Expressed with high intensity in orthokeratinized layers. In orthokeratinized layers, and with less intensity in parakeratinized. Okay, remember this point. They are present in high amounts in orthokeratinized compared to parakeratinized layers. Okay, next comes the second is keratin proteins K6 and K16. This is also, remember, K6 and 16 will come together only. They are present in highly proliferative epithelia. They are present in highly proliferative epithelium. Okay, next is K5 and K14. They are stratification specific cytokeratins. They are, sorry, stratification specific cytokeratins, and they are also present in the outer oral epithelium only. Remember that K19 is absent in orthokeratinized, and present in parakeratinized. Now don't ask me the reason, guys. I don't know. This is just a fact and you have to remember it. Okay, this is asked in exams. K19 is absent in orthokeratinized layer. K1 to 10, 11 and 12 are present in high intensity in orthokeratinized. K19 is absent in orthokeratinized, okay, and it is present in parakeratinized epithelium. So this is about the oral epithelium. Now similarly, the cytokeratins are present in sulcular epithelium also. They are present in junctional epithelium also. Okay, so that also we will see right now only. Cytokeratins present in sulcular epithelium, or cytokeratins in sulcular epithelium, present or absent in sulcular epithelium, in sulcular epithelium. Now K19 is present in sulcular epithelium. K19, which is absent in orthokeratinized, is present in parakeratinized. It is also present in sulcular epithelium. Okay, K19 is present here. It lacks K1 to 10, 11 and 12. Okay, it has K4 and K13. This is not important. What important proteins do you need to remember is K19. It is present here and it lacks this protein. Okay, now in junctional epithelium, the cytokeratins in junctional epithelium. Cytokeratins in junctional epithelium. This also has K19. K19 is present here. K6 and 16, we have studied here that K6 and 16 are present in a highly proliferative epithelium, and junctional epithelium is one such epithelium, right? Junctional epithelium is a highly proliferative epithelium. We will study that. So that junctional epithelium, though it is highly proliferative, but K6 and 16 are absent in junctional epithelium. K6 and 16 are absent in junctional epithelium. It has K5 and 14. These are stratification specific proteins which are present in junctional epithelium. Okay, so this is about cytokeratins in oral epithelium. Though difficult to learn, or though difficult to understand, but guys, please write it down somewhere and try to learn it. Okay, so this was about the oral epithelium. Now, after the oral epithelium comes the connective tissue. Now, in this connective tissue, the epithelium and connective tissue, there is a layer. There is a layer which connects the epithelium and the connective tissue, which is present at the base of the stratum basale. This layer is called as basement membrane. This layer is called as basement membrane, and this basement membrane is 300 to 400 angstrom thick. This basement membrane, it connects the epithelium to the connective tissue, and the important point here is it is 300 to 400 angstrom thick. This basement membrane, it is made up of two. This basement membrane is made up of two layers. The above layer is called as lamina lucida because it is lucid, it is transparent, and it is rich in laminin protein. Okay, this above layer is called as lamina lucida and it is rich in protein laminin. Next is lamina densa. This layer is called as lamina densa, and this layer it is very much rich in collagen type 4. There is cross-linked collagen, and that's why it appears dense in the microscope. It is rich in collagen type 4. This basement membrane is connected to the underlying tissue with the help of certain fibrils which run like this. These are called as reticular fibers, anchoring fibrils, and these anchoring fibrils are rich in collagen type 7. Not that important, just for general knowledge, collagen type 7. Okay. The basal cells are connected to the basement membrane. The basal cells are connected to the basement membrane with a structure called as hemidesmosome. It is connected with, like this, it is connected with hemidesmosomes. So remember that cell to cell connection. The cell to cell connection is with the help of desmosomes, and the cell to membrane connection, this connection, is with the help of hemidesmosomes. Hemi means partially on the membrane, partially onto the cells. Okay. Now, in sulcular epithelium, there is not much to remember. Just remember that sulcular epithelium, the structure of the sulcular epithelium is similar to that of a non-keratinized epithelium. Okay, so it will have stratum basale, it will have a stratum spinosum or a prickle cell layer, then there will be an intermediate layer, then there will be a superficial layer, but it will not be keratinized. And remember that sulcular epithelium is a semi-permeable membrane. Sulcular epithelium is non-keratinized. Okay. Sulcular epithelium is non-keratinized, and it is semi-permeable. Okay. Next, a very important epithelium is the junctional epithelium. We will be studying about this junctional epithelium throughout gingival diseases, specifically in periodontal pocket. Also, we will study about this and pathogenesis of pocket formation. So, junctional epithelium is a very important structure. Okay. Just hold on, guys. I don't know why the pen is not working. Hmm. Okay. So this is what is junctional epithelium. The junctional epithelium is located below the sulcular epithelium. If I'll show you in this diagram. So here, this is the sulcular epithelium, and here you can see that there is junctional epithelium. Okay. Hmm. This is the junctional epithelium, which you can see here, whole of this. And this junctional epithelium starts at the apical end of the sulcular epithelium, that it connects the tissue, the connective tissue, the gingiva to the tooth surface. Now, in periodontal pocket, we will be studying this in detail in later classes, okay? But what happens in periodontal pocket formation? Because of plaque accumulation, there is apical migration. There is apical migration of this junctional epithelium, and therefore whole of the structure of the sulcus, it moves apically, and that results in the formation of pocket. And how that pocket forms, that we will study in the chapter periodontal pocket, okay? So now don't ask me how the pocket forms in the doubts. Now, in the junctional epithelium, it is a multi-layered structure, okay? Junctional epithelium is a multi-layered structure. It surrounds the tooth in a collar-like fashion. It is located below the sulcus epithelium. Gottlieb called it as epithelial attachment. Weyerhohn called it as epithelial cuff. So sometimes you can see in MCQs that the different names that can be used instead of junctional epithelium are epithelial attachment, which was given by Gottlieb. Okay, I'll write it down here. Junctional epithelium can be called as epithelial attachment. This name was given by Gottlieb. Okay, or it can be called as epithelial cuff also. This name was given by Weyerhohn. Okay, so if in exams or if in MCQs it is asked as epithelial attachment or epithelial cuff, don't get confused. It is your junctional epithelium only. Now, junctional epithelium in early life, it is 3 to 4 cell layer thick. Junctional epithelium in early life, it is 3 to 4 cell layer thick. And as the age increases, it becomes 10 to 20 cell layer thick. As the age increases, it becomes 10 to 20 cell layer thick. The length or the width of junctional epithelium, this is important. The length of junctional epithelium is 0.25 to 1.35 mm. Average, you can tell it as 0.97 mm. And it is the only epithelium, this is also important, only epithelium in whole body, only epithelium in whole body with two basement membrane or two basal lamina. Now let us see the structure. So these are the cells. The cells are similar. They have stratum granulosum, they have stratum spinosum, intermediate layer, superficial layer. Okay, but it is unique in a way that there are two basal lamina present. This basal lamina which you see here, this is the external basal lamina, and it is towards the connective tissue side. So it is called the external basal lamina, and one basal lamina is attached to the tooth. This basal lamina is attached to the tooth and it is towards the tooth surface. It is called as internal basal lamina. The cells, sometimes this question is never asked, but this is just a general information. The cells which are the cells, the keratinocytes which are nearer to the tooth, these cells are called as DAT cells. DAT cells, also called as directly attached to the tooth cells. Okay, this is what is junctional epithelium. Now, junctional epithelium along with the connective tissue or the gingival fibers is called as dentogingival unit. Now, Again, that diagram is very important, guys. Everything you have to correlate with this picture only. Okay. So, junctional epithelium. This junctional epithelium along with the gingival fibers, all of these here, gingival fibers are there. This is also we are going to study after this only. So, this whole unit together, this is called as dentogingival unit. This is called as dentogingival unit, another important topic for MCQs. Okay. Dentogingival unit is junctional epithelium plus gingival fibers. This is what is your dentogingival unit. Okay. Now, another concept, and this is the last concept which is an important concept, and we will be discussing this in this YouTube live session. After this, we will take a break and then we will start our classes on the app. Okay, guys. So, the next important thing is the concept of biologic width. What is this biologic width, right? We get confused that what is this biologic width. So guys, biologic width is the length of the junctional epithelium and the connective tissue up till the alveolar crest. Okay, so this, again going back to this diagram, the gingival fibers and the junctional epithelium constitute the dentogingival unit. Okay, now here is the junctional epithelium. Here is the junctional epithelium and there is connective tissue. So this connective tissue along with junctional epithelium, this and the connective tissue up till the alveolar crest, whole of this is called as the biologic width. Understood? Junctional epithelium, the length of junctional epithelium along with the connective tissue up till the alveolar crest is called as biologic width. Okay, this biologic width, it is very important in whenever we have to, plan our prosthesis, whenever we have to place restorations for root caries, whenever we are doing crown lengthening, this biologic width is very important. The biologic width is junctional epithelium length plus the connective tissue above alveolar crest, which is junctional epithelium we studied. The average value was 0.9 plus the connective tissue above the alveolar crest is 2.09 mm. Sorry, 1.09 mm. So the biologic width is equal to 2.09 mm. So approximately the biologic width is 2 mm. Now let us go back to the radius of action of bacteria. It is 2 to 2.5 mm. Okay, I told you if this is the tooth, okay, here there is plaque accumulation here there is plaque accumulation, there is loss of gingiva here, plaque accumulation is here, and this biologic width is less than, the biologic width is not maintained and it is less than 2 mm. Okay, I don't know why this pen is not working. This biologic width is, this biologic width is less than 2 mm. So what will happen? The bacteria will come here, it will release its toxins. The bacteria which are here, right? The bacteria which are here, the bacteria which are here, they will release the toxin and they will easily invade the bony tissue, the connective tissue, and they will start the destruction of bone. Understanding little bit concept, they will start the destruction of the bone. That's why biologic width is very important, because the radius of action of bacteria is 2 to 2.5 mm. If this biologic width is hampered, suppose I am placing my crown, if this is the tooth, okay, here is the tooth. I am placing a restoration over here. This is a normal tooth, normal anatomy, normal gingiva. This biologic width is 2 mm. Here the width is 2 mm. Okay. This width is 2.5 mm. Suppose biologic width is 2.5 mm. Now what I have done is I have placed a crown and I have placed the crown subgingivally. This space, this biologic width is hampered. Now what will happen is there will be plaque accumulation here. Now don't tell me that plaque will not accumulate. Plaque will definitely accumulate. It is oral cavity. Every day the patient is not coming to you and getting the scaling done. The plaque will accumulate. Okay. So now here the plaque will start accumulating, the bacteria will accumulate and it will start releasing its toxins and it will be nearer to the bone. So there will be early destruction of the bone. So that's why you have to take care whenever you are planning any prosthesis, whenever you are placing any crown over a tooth. Check what is the means how much sulcus depth is there. If 2 mm sulcus depth is there, then you can go below the sulcus, right? You have to check that the sulcus depth is, that's why very important. So that's why biologic width should not be hampered. Why this biologic width should not be encroached? Why should biologic width not be encroached upon? Encroached upon because it will lead to increase in inflammation, increase in inflammation, increase in connective tissue destruction, and increase in bone loss. There will be more pocket formation, more recession will be there in cases where the biologic width is hampered. So 2 mm of biologic width should every day, anytime should be maintained, whether you are placing a crown, whether you are placing a restoration, okay, whether you are doing crown lengthening. Understood? So this is the concept of biologic width. With this, we are stopping here. I'll continue with the gingival fibers in the app. Okay. And I'll just check if there are any doubts. Don't bone sounding or transgingival probing affects the attachment of gingiva. No, it doesn't, because we are just, it is a very large structure and we are just penetrating it with the probe. Ma'am, how to calculate recession while calculating clinical attachment loss? From the marginal gingiva up till the cemento-enamel junction. Are there any other doubts, guys? Okay. So with this, we are completing the session here. Now next I will be teaching about the gingival fibers, the dentogingival unit in short, and then we will go to periodontal ligament fibers, and then we will go to start with dental plaque. Let us see what time permits. So thank you so much, guys, and let's take a 15 minutes break and then see you again. Bye. Okay, one doubt is there, ma'am. Soft palate is keratinized or non? Soft palate is, it is parakeratinized. Soft palate is parakeratinized. Okay. Initially it is parakeratinized, and as we are going downwards and it is becoming a part of nasopharynx, it becomes non-keratinized. Okay, guys. So thank you so much, and see you soon on the app.